In 2022, a man named Michel Roccati walked into a room under his own power. That sounds unremarkable until you know that 5 years earlier, a motorcycle accident had left him completely paralyzed from the waist down. Not partially, not with some sensation remaining. Completely. No movement, no feeling, nothing. What allowed him to walk was not a miracle, not a surgical cure, and not some experimental drug. It was a combination of a wearable robotic exoskeleton and a surgically implanted device smaller than a matchbox. And it worked so well that he was able to climb stairs. This is not a distant research promise. This technology exists right now, it is being refined right now, and the implications reach far beyond spinal injury. We are standing at the edge of a fundamental redefinition of what paralysis actually means. For decades, a severed spinal cord was treated as a permanent sentence. The medical consensus was blunt. Once the signals stop, they stop. What is now being demonstrated in clinics across Europe, the United States, and Japan is that this consensus was wrong, or at minimum, dangerously incomplete. There are roughly 5.4 million people living with some form of paralysis in the United States alone. Globally, the number sits closer to 250 million when you factor in stroke-related paralysis, progressive neurological conditions like multiple sclerosis, and traumatic spinal cord injury. The economic burden in the U.S. alone exceeds $40 billion annually in direct care costs, and that number does not account for lost productivity, psychological deterioration, or the cascading health complications that come from a life spent immobile. Pressure ulcers, cardiovascular decline, bone density loss, chronic pain. Paralysis is never just one condition. It is a doorway into a system of compounding failures. The urgency here is not abstract. Robotic exoskeleton technology has crossed a threshold in the last 3 years that separates laboratory demonstration from genuine clinical deployment. The companies developing this technology, Exobionics in the US, Rewire Robotics, Swiss-based Sensars Neuroprosthetics, and the team at EPFL in Lausanne, are not working on version 1 anymore. They are working on version 3 and 4. Insurance systems in 5 countries are currently deciding whether to cover exoskeleton-assisted rehabilitation, and those decisions will either accelerate access for millions of people or delay it by a decade. That window is open right now. To understand why this technology matters so deeply, you need to understand what spinal cord injury actually is at a mechanical level. The spinal cord is essentially a highway of electrical signals connecting your brain to your body. When you decide to lift your foot, your brain sends a signal down that highway. It reaches the leg muscles, and the muscles fire. A spinal cord injury does not destroy the muscles. The leg muscles of a paralyzed person are often completely intact. What gets damaged or severed is the highway itself, the transmission line between intention and action. For most of the 20th century, medicine focused on repairing or bypassing that highway, and largely failed. Scar tissue forms rapidly after injury, and nerve regrowth in the spinal cord is almost non-existent without intervention. The field spent decades hitting a biological wall. What researchers eventually asked was a different question entirely. What if you do not need to repair the highway? What if you just need to reroute it? That rerouting is called epidural electrical stimulation, and what it does is genuinely astonishing. In the landmark 2018 study published in Nature, for patients with complete or near-complete paralysis, all regained voluntary leg movement within 1 week of having a small electrode array implanted along their lower spinal cord. Not after months of physical therapy. Within 1 week. The device delivers precisely calibrated electrical pulses directly to the lumbar region of the spinal cord, essentially waking up the neural circuits that control walking. Those circuits did not die in the injury. They went dormant. The stimulation gives them just enough signal to reactivate. Think of it like a car with a dead battery. The engine is fine, the fuel is in the tank, but nothing starts without that initial jolt of electricity. The stimulator provides that jolt continuously, and when paired with a wearable exoskeleton that supports the body's weight and guides leg motion, patients do not just regain movement. Some regain it outside the lab. Here is where the second layer of this story becomes genuinely mind-bending. The assumption in neuroscience for the better part of a century was that adult nervous systems do not rewire themselves in any meaningful way after severe injury. Neuroplasticity, the brain's ability to form new connections, was considered a feature of development, not recovery. What the EPFL team discovered, working with patients like Michel Roccati and 2 others published in the journal Nature Medicine, completely overturns that assumption. After several months of exoskeleton-assisted walking with epidural stimulation, patients began showing voluntary movement even when the stimulator was switched off. The nervous system had used the repeated, electrically assisted experience of walking to grow new signal pathways around the injury site. In Roccati's case, nerve fibers that had shown no activity in post-injury imaging began producing measurable signals years after his accident. The spinal cord was rewiring itself. One of the 3 published patients regained the ability to walk short distances with only a crutch and no stimulation at all. That result was not predicted by any existing model of spinal cord injury. It suggested that the window for recovery does not close the way everyone assumed. The technology itself works through a tight loop between 3 systems. The exoskeleton is a rigid but lightweight frame that straps around the torso, hips, and legs. It contains electric motors at each joint, hip, knee, ankle, and sensors that detect the user's intent through subtle shifts in body weight, muscle surface activity picked up by external electrodes, or direct input from the implanted stimulator. The stimulator itself sits surgically against the spinal cord, not inside it, and communicates wirelessly with the exoskeleton's control unit. When a user initiates a step by shifting their weight forward, the sensor array registers that intent. The exoskeleton's motors begin moving the leg through the correct walking arc, and simultaneously the stimulator delivers a pulse pattern that triggers the dormant lumbar circuits to fire and sync. The 2 systems reinforce each other, like a conductor and an orchestra playing the same score. The counterintuitive part is that the body does not feel passive in this process. Users describe feeling like they are walking, not being carried, because the neural stimulation engages real muscle activation. The muscles are doing real work. The exoskeleton is guiding, not substituting. The complications here deserve honest attention. First, not every patient responds. The current published success rate in the EPFL cohort was 3 for 3, but that cohort was carefully selected. Patients with significant damage to the lumbar circuits themselves, rather than higher cord injuries, may not have dormant circuits to reactivate. The technology currently works best for injuries at the thoracic level and below. Second, the cost is prohibitive. A full exoskeleton system runs between $70,000 and $150,000 depending on configuration, and the implanted stimulator adds surgical costs that can exceed another $50,000. Most insurance systems do not cover this. In the U.S., Medicare and private insurers classify exoskeleton use as rehabilitative equipment, not medically necessary, a classification that advocates are fighting but have not yet overturned. Third, long-term data is still thin. The oldest published follow-up in any exoskeleton stimulation patient is under 5 years. Implant longevity, battery replacement, and what happens to rewired neural pathways over decades are genuine unknowns. If you have a family member with a spinal cord injury or progressive neurological condition like multiple sclerosis or ALS, the timeline you need to watch is the next 3 to 5 years. The EPFL team, now working under a spin-out company called Onward Medical, expects to begin broader clinical trials across European hospitals by 2027. Rewire Robotics received FDA clearance for home use in the US in 2015, but the integration of their hardware with stimulation implants is pending regulatory approval expected in late 2026. If your family member's injury is at the thoracic level and less than 15 years old, they may qualify for current trials. The website Clinical